deep inside the arterial walls, lipid-filled plaques accumulate in near total silence, steadily narrowing the vessel until the structural pressure reaches a breaking point. When that pressure demands pharmacological intervention, the response follows a rigid, multi-branched decision tree, rather than a general prescription. This is the master clinical algorithm, the definitive navigational map clinicians use to determine specific treatment paths. It categorizes patients based on metabolic profile and cardiovascular risk, dictating which drug therapy is assigned. Skipping these diagnostic steps increases the likelihood of inappropriate drug selection and unrecognized side effects. The first priority is addressing underlying triggers before initiating lipid-specific medication. Hypothyroidism, the glowing orange gland, artificially elevates lipids. Hepatotoxicity from chronic alcohol intake can mimic primary hyperlipidemia. Finally, common pharmacological treatments like thiazide diuretics and beta blockers often induce iatrogenic lipid elevation. Resolving these underlying causes frequently stabilizes lipid levels without the need for long-term pharmacological intervention. If no secondary causes are found, the algorithm moves to the primary prevention branch. This silver balance illustrates the pharmacological threshold. Medication is indicated only when dietary modification fails to reach targets. The clinician calculates a 10-year risk assessment. Adults must demonstrate a 20% or greater cardiovascular risk to justify medication. This risk score pairs with a specific biochemical trigger, total cholesterol exceeding 5.5 millimoles per liter. When both risk and biochemical thresholds are met, the algorithm designates a statin as first-line therapy. Statins work by binding to specific cellular receptors. This action halts lipid synthesis, preventing the golden spheres from entering the bloodstream. Primary prevention requires both verified long-term risk and this specific biochemical threshold to move forward. If a patient cannot tolerate statin therapy, indicated by the red rejected strap, the algorithm pivots to alternative agents. The first alternative is a fibrate. The second option is Ezetimibe. The third option involves bile acid resins. These agents operate locally within the intestinal tract rather than systemically. When faced with statin intolerance, clinicians require a seamless transition to one of these three backup systems to safely maintain patient lipid control. All previous thresholds change when the patient moves into the secondary prevention pathway. For patients with established disease, the standard 5.5 millimole threshold is bypassed. Ischemic heart disease requires this immediate intervention because the cardiac tissue is already at high risk. Cerebrovascular risks also demand this bypass. A history of stroke or transient ischemic attacks necessitates immediate lipid lowering. Peripheral vascular disease and diabetes follow the same aggressive protocol. Both conditions require immediate pharmacological intervention regardless of initial lipid levels. When end organ damage is present, the algorithm prioritizes immediate protection over conservative screening. However, when high triglycerides emerge as the primary issue rather than cholesterol, the entire treatment protocol undergoes a fundamental and immediate shift. Fibrates are the first-line therapy here. The white geometric cage represents the drug binding to the green Y-shaped triglyceride structures. If fibrates are insufficient, nicotinic acid can be used as a secondary agent. Omega-3 acid ethyl esters, like Omacor, provide adjunctive support. This amber oil helps break down the triglyceride models shown here. Identifying the specific lipid type allows the clinician to select the most effective pharmacological agent. Mixed hyperlipidemia involves the concurrent elevation of both high cholesterol and high triglycerides, as shown in the left panel of this diagram. In a mixed profile, monotherapy addressing only one pathway leaves the other lipid elevation unaffected. The algorithm addresses this with a combinatorial strategy. A statin serves as the central component of the treatment plan. This hub is then augmented by secondary agents. Fibrates or Ezetimibe are added to the statin to manage the triglyceride load. By implementing this multi-pronged approach, it utilizes targeted combination therapies to simultaneously address every elevation present in the patient's complex metabolic profile. Returning to the full view of the master clinical algorithm, we can see how these branches form a complete protocol for clinical decision-making. Success depends on identifying underlying causes before treating laboratory values. The protocol balances a conservative 20% risk threshold for healthy adults with an aggressive bypass for patients with established disease. Drug selection is then carefully tailored to the specific lipid phenotype, using either single agents or multi-drug combinations. Professional efficacy and lipid management depends on the disciplined application of this algorithm to every patient profile.